Hello, everyone, and welcome back to the Clinics Review Articles podcast. I'm Taylor Hayes, Clinics Editor at Elsevier, and I'm here with my colleague, Clinics Editor Megan Ashdown. Joining us today is Dr. Joel Heidelbaugh, Clinical Professor of Family Medicine and Urology at the University of Michigan Medical School in Ann Arbor, Michigan. Dr. Heidelbaugh serves as the consulting editor of primary care clinics and office practice and is the editorial advisor for our Clinics Collection series. Clinics Collections draws from Elsevier's robust Clinics Review Articles database to provide multidisciplinary teams with practical clinical advice and insights that can be implemented in individual specialties and everyday practice. Our November 2025 edition focuses on obesity management, and we're excited to have Dr. Heidelbaugh back with us today to talk through several featured articles and what they mean for clinicians.
Welcome, Dr. Heidelbaugh. We'll kick things off with the first article we'd like to discuss on applying an equity lens to pediatric obesity, clinical, environmental, and policy considerations for clinicians by Drs. Colin J. Orr, Michelle C. Gorick, and Jennifer A. Wu Badel. First, what are the key societal and structural factors contributing to disparities in pediatric obesity?
Well, thank you, Megan, and thank you, Taylor, for inviting me to talk about this important Clinics Collection series on obesity management today, a multidisciplinary approach. So this particular article, Applying an Equity Lens to Pediatric Obesity, really centers on clinical, environmental, and policy considerations for clinicians. And the key societal and structural factors that contribute to disparities in pediatric obesity are really seen across all of our practices, whether it's a pediatrics practice, a combined internal medicine and general pediatrics practice, or even in family medicine. And so a lot of those disparities are really seen across race, ethnicity, socioeconomic status, poverty, geography, gender identity, and any implicit or explicit exposure to discrimination. And so we know that a lot of these factors really help shape that lens through which clinicians are really going to think about how we define and address and treat pediatric obesity. And so the key societal and structural factors are really many of those intertwined with the elements within our practices, whether our practices are in urban or suburban or even rural communities.
That's great. So the authors also reference several health equity frameworks, including those from the National Academies of Medicine. Can you explain the significance of these frameworks in understanding pediatric obesity disparities?
Sure. And so for those of you who may be following along with the book, just to reference, there's a great table that lists these frameworks on page 34. And it highlights not only each individual framework, but the relevant details, and then the level, whether it's the health system level or the societal or policy level. I'm not going to read through each one of these, but in particular, the one by Gurewitch and colleagues talks about proposed relationships within health systems. And the importance of this is really to reduce health disparities by identifying those social drivers to improve health outcomes. Many offices now and many practices now will have social determinants of health questionnaires or other such tools to be able to work to identify many of these constructs and factors that allow the clinicians to be able to engage in really robust discussions with the families, the parents and the children or adolescents, and try to identify these barriers to promote good health outcomes.
And so last question on this article, the authors highlight prenatal factors as well that influence childhood obesity risk. What are those prenatal factors and how do these disparities manifest across different communities?
Sure, and just like with any patient interaction, certainly prenatal care merits taking a very detailed maternal history, not only medical history, but psychosocial history as well. Probably the most important prenatal factors really have to do with gestational diabetes and maternal BMI or body mass index prior to conception, certainly early and throughout pregnancy. Those disparities manifest across different communities really by exploring other avenues about access to healthcare, access to food, access to adequate nutrition. Over time, I've learned, and this is referenced throughout the book a lot here, many different options for increasing nutritional awareness and dietary services even throughout prenatal visits. And I think those things are important not only to address the health of the mother, but certainly how this impacts future childhood obesity risk.
Moving to the second article, let's discuss the article Weight Stigma by Dr. Amanda Velasquez. The authors define weight stigma as misconceptions and stereotypes associated with higher body weight, is pervasive across all levels of society, including healthcare. It manifests at the individual and interpersonal levels, influences community and institutional settings, and extends to cultural norms. What does it look like in day-to-day healthcare settings, and what are some practical steps clinicians can take to reduce weight stigma in their own practice and create a more supportive, respectful environment for patients?
Sure, I think it's a great question, certainly an important one. I'll admit ultimately what happens, and I'm very guilty of this as well, is we have to keep track of problems and we have to keep track of medical diagnoses. In fact, in my medical system, there's a prompt that even reminds me to flag that a patient has obesity and put it on their problem summary list. And obviously, this is visible for the patient to see. So if you have a body mass index over 30, immediately I'm labeling that and I'm putting that on the problem list. Now, we do that in a way that helps us really focus in on the impact of obesity relative to overall health and comorbidities. But certainly, in a lot of ways, that's even creating a stigma because we're labeling it and we're labeling people that way. And so many of us will really engage in supportive conversations with our patients about how things are defined and looking just beyond the number of weight, looking just beyond body mass index, looking at body plasmography, looking at percent body fat, looking at abdominal waist circumference. And not only that, but when you talk about building a more supportive and respectful environment for patients, taking a look at where we are today and taking a look at a health goal to figure out where we're going to be tomorrow.
Yeah, I like what you said about looking beyond the numbers and really hoping to support and engage in these important conversations with patients to develop a plan that works for them. This article also tackles several deeply ingrained myths about obesity, ideas like being purely a matter of willpower, the belief that obesity is not a disease, or the notion that medications and surgery are somehow the easy way out. Why do you think that these misconceptions persist, and what impact do they have on patients and the care they receive?
Sure. So I'm going to make the disclaimer that I'm not a dietitian, and I'm going to make the disclaimer that although I'm not an obesity expert, I've been a family physician for 27 years. And we have this challenge in terms of how we provide education and support for our patients. I don't know how many diet books are on the market. I don't know how many diet plans are in existence. But if there was one that worked, there would only be one, and it would work for everyone. And we all know that this is not a one-size-fits-all model. So we don't want to talk about obesity as a disease or as a label. We talk about it as a comorbidity relative to other medical comorbidities a patient may have. And that could include heart disease. That could include depression. We talk about setting goals. And relative to the misconceptions about how medications and surgery are somehow the easy way out, I don't look at it that way. I actually look at it as these are potential options to help people. We live in an age now where previously we did not have great medications to help people lose weight. We had some, they didn't work well, they had a lot of side effects, and they were not designed to be long-term drugs. That's all changed. We have several different options now, several different classes of medications, which have great results and great evidence behind promoting and sustaining weight loss. So for some patients, this has been revolutionary, similar to bariatric surgery.
Thank you. And similarly, when you mentioned that there isn't a one-size-fits-all solution, there also is not a universally accepted way to start conversations about weight with patients. For providers who want to be thoughtful and respectful, how can they broach the topic of weight in a way that builds trust and avoids stigma while also opening the doors to a productive and collaborative discussion?
Well, I can explain to you what I've learned, and what I've learned actually came from patients. And I've listened to patients over the years enough to know that it's difficult for them to bring it up and it's difficult for them to talk about it. However, many do, and many want that help. And what I've learned is people deserve the opportunity to tell their story of their successes and their challenges. People deserve the opportunity to say, when I graduated high school, I weighed this much. Now that I'm 50, I weigh this much. I used to do this. I used to do that. And you take the opportunity to listen to what they've tried, what's worked, and what hasn't worked. I don't like to use the term failure because everyone at some point has had some success in weight loss. Maybe people haven't had the sustained weight loss, but I want to learn what people have tried and what people have had some success with. And then it gets into setting goals, and then it gets into understanding that there will be forward advances, there may be some setbacks, but we're here to support them. When a patient comes in, and even if they've lost 1 or 2 pounds, I explain to them that that's a victory, and we're going to keep planning and moving forward.
I love that perspective, and I think it's so important to stay curious about your patients and ask the right questions. So you talked about obesity medications briefly. Let's circle back to that and discuss the article on weight loss pharmacotherapy, current and future therapies by doctors Gabriella Jordan, Singrid Young, and Jose O. Alleman. Yeah. They note that most FDA-approved medications typically lead to about a 5 to 10% total body weight loss, while newer GLP-1 agents can reach closer to 17%. How do these differences change the treatment landscape for clinicians?
Sure. Well, this is a great article, very well written, very informative, and certainly the GLP-1 agonists have really permeated American and worldwide households just in terms of name alone. We're all familiar with them, we've all heard of them, and we all know somebody who's taking them. Recent data shows that 1 out of 6 people in the United States of America is taking a GLP-1 agonist. And a lot of the data has been really impressive. There's about a 15% non-responder rate, which means that about 15% of patients either don't tolerate them due to adverse effects or don't lose substantial weight on them. But some of the data has really, really been remarkable. I've seen as high as 20 or 30% or even higher. So how does this change the treatment landscape for clinicians? Well, it's another option. And this particular class of medications has proven benefit in not only weight loss, but improving glycemic control in patients with diabetes, obstructive sleep apnea, minimizing risk of metabolic-associated steatohepatitis or liver disease, and many other comorbid factors. And I really think we're only starting to see a lot of the beginning research relative to good outcomes on these medications.
Yeah, I'm really glad we got a chance to touch on this because GLP-1s, as you mentioned, are increasingly popular. Next, the article describes how orlistat reduces fat absorption by 30% and has been shown to help with weight plateaus after bariatric surgery. In your experience, in what situations does orlistat remain a strong first-line option despite its gastrointestinal side effects?
Sure. So orlistat has been around for a few decades. It basically works to decrease fat absorption so that it promotes excretion of a lot of fat in the stools. With that comes gastrointestinal side effects such as abdominal cramping, bloating, and fatty or greasy stools, which can be untoward for many patients. In what situations does it remain a strong first-line option? This medication's over the counter. It's certainly cheaper than many of the newer medications, and it may be a reasonable first-line option for patients if they can tolerate it.
That's good to know. We'll move on here. We also see data from phase 3 trials showing that phentermine and topiramate can lead to anywhere from 5 to 10% weight loss, depending on the dose. What patient profile makes this combination particularly effective or contraindicated?
Sure. So the combination of phentermine and topiramate has also been used, and some of the data shows upwards around a 10% weight loss once patients are on the higher doses. It ends up being, in many cases right now, and I think this will be a moving target over the years, but right now, for many insurances, that medication along with naltrexone and bupropion, are often first-line agents or recommended because they may be cheaper. The combination of phentermine and topiramate works well to decrease hunger, and it can boost metabolism. Generally fairly well tolerated, often contraindicated in patients with uncontrolled hypertension or certainly other cardiovascular issues that you would not want to put in consideration or combination with phentermine.
And one more question here on obesity medications. While naltrexone and bupropion can be effective, it carries important contraindications, including but not limited to uncontrolled hypertension, seizure disorders, and chronic opioid use. How should clinicians weigh these risks when considering it for patients with complex medical histories?
Sure. And so naltrexone has a great indication for decreasing cravings. We know about opioids, we know about alcohol, and also now relative to hunger. And the combination of that and bupropion has been effective in promoting weight loss as well. Again, often a first-line option along with phentermine and topiramate relative to cost-effective issues, as GLP-1 agonists can be cost prohibitive for some patients and insurance plans. It's important to take a thorough history. It's important, like with any other medication that you would prescribe, to talk about indications, but also potential adverse effects or contraindications. And so taking a thorough history in these patients is going to be really effective and really key relative to prescribing any of these medications we've mentioned.
Switching gears from medications to prevention, the last article we'll discuss today is Promoting Healthy Eating and Activity from the Start, Early Obesity Prevention by Drs. Corey B. Flower, Jessica Hart, Heather Wright-Williams, and Rebecca Chasnovitz. To begin, let's talk about the earliest moments of obesity prevention. In the newborn period, how can clinicians more effectively promote exclusive breastfeeding?
Sure. Well, I'll admit my biases here, and I've done prenatal care for 27 years. We talk a lot about maternal preferences for infant feeding. We provide a lot of education. Certainly, we try to promote breastfeeding if and when at all possible, unless there's specific preferences against it or contraindications to it. But we certainly try to promote exclusive breastfeeding. And not only that, really exclusive breastfeeding within the first 6 months. And certainly a need to delay any baby foods or infant foods prior to that.
The article also describes how individual level counseling on healthful eating and physical activity can make the most of pediatric clinicians' frequent contact and relationships with families in early childhood years. During routine well visits, pediatric clinicians have a lot to cover in a very short amount of time. What strategies work best to help families understand and adopt early obesity prevention behaviors?
Sure, it's true. We do have a lot to cover in a very short amount of time. But one thing parents are always interested in is, how is my child developing? How is my child growing? And are they on track? So one key thing that many of us do will actually show the graphs, will show the weight curves, will show the trajectory of how the child is gaining weight or gaining height or length or head circumference. But focusing specifically on weight, everyone can read a graph and everybody can make sense out of a graph. And so I think showing that really helps parents to understand where the child is at that point and where the goals are. Relative to understanding obesity prevention, let's just fast forward this into the particular child is 3, 4, 5, 6 years of age. Where do they fall on the growth curve? You point out where the average is of where they should be. And certainly if they're well above the curve, and we've all taken care of children who are above the growth curve, even at that early age, we talk about an intervention at that point to talk about clear nutritional strategies and goals, maintaining adequate vitamins, minerals, nutrients, calories, but figuring out how to screen for obesity problems that children are going to have later and work to support them so that it does not become a compounded problem over time.
The authors also highlight several modifiable behaviors, including breastfeeding support, bottle size, screen time, and early feeding practices. We also know that early childhood eating and activity patterns are shaped not just at home, but childcare settings, community opportunities, and even local and federal policies. How can clinicians use their frequent well child visits to effectively counsel families on healthy eating and activity while also acknowledging these broader societal and environmental influences?
I think that's probably one of the most important questions we're going to cover today. Certainly, feeding and feeding patterns, nutrition, weight gain, and developmental trajectory are going to be key cornerstones of any well child exam, but also any pediatric visit in the office for that matter. Certainly, trying to understand how the family feeds the child, when they feed the child, how much they feed the child, and really trying to categorize everything that they eat and when is a big task and a big task to do in any visit. But when we're focusing on obesity management or obesity prevention, taking a good history, you're going to learn a lot. I'll give you a quick example. I recently saw a 5-year-old who's already more than double his expected weight. And when I was asking mother about feeding habits, she kept saying he eats good, he eats well. She was saying all the right stuff. And then during the visit, the 14-year-old sister gave the 5-year-old her Frappuccino. And one, that's a lot of caffeine for a child 5 years of age. I don't think we can dispute that. But two, that's a lot of calories. And, once you start getting a history in terms of other things that children are eating, those calories really add up, that it's an opportunity to sort of understand how they view that, because the family in that particular situation didn't really view it as a problem. They felt that the child liked it, therefore it must be acceptable.
And lastly, beyond one-on-one counseling, sharing the data with families, and screening for future obesity problems, what role do you see clinicians playing in advocating for broader system-level changes, such as improved access to lactation support, nutritional resources, or community physical activity programs that help families build and sustain healthy habits?
Another great question. It really starts with our practices and building and maintaining that relationship where the parents are going to bring the children in consecutively and consistently so that we see them longitudinally over time and that there aren't any gaps in their care. Certainly, depending on where we are and the systems that we work in and what our communities look like, we're all going to have various levels of resources. But engaging with social work, engaging with community partners, engaging with the insurance companies is going to allow us to determine what resources exist in the community. It doesn't take a lot of work to find out from any given insurance company what they will cover. Will they cover lactation support? Will they cover nutritional classes for a child who's headed toward obesity? Will they cover physical activity programs in after-school settings? How do we learn what resources exist in the schools? Many of the schools have nutritional support services or have clinician services in the schools themselves. Certainly there's physician presence and allied healthcare professional presence in the school systems, and these can serve as great educational tools and great resources for children.
And that brings us to the end of today's episode. Dr. Heidelball, thanks for joining us and for sharing your expertise on the evolving approaches to obesity management. If you'd like to purchase this Clinics Collections issue or explore recent editions on breast cancer, heart disease, COVID, telehealth, or even addiction medicine, visit us.elsevierhealth.com. To learn more about the Clinics Review Articles program, which spans nearly 60 medical specialties, head over to theclinics.com. You can also follow us on Twitter at Clinics Reviews and subscribe to the Clinics Review Articles podcast on Apple Podcasts, Spotify, YouTube, or any other major streaming platforms. Thanks for listening, and we'll see you next time.